It's my pleasure to welcome you to tonight's webinar, which is entitled An Approach for Prevention, Diagnosis, and Treatment of Oral Cancer. Our featured speaker tonight is a very distinguished Dr. Alfred Wyatt. Dr. Wyatt received his BS degree in biology from Clark College, his DMD from the Medical College of Georgia School of Dentistry. His dental organization affiliations include the National Dental Association, the American Dental Association, Georgia Dental Society, Georgia Dental Association, the North Georgia Dental Society, the Christian Dental Society, and the Hinman Dental Society. He is also a member of the Academy of Laser Dentistry, where he has served on the board of directors and attained advanced proficiency and educator status. Presently, he is chair of the Education Committee of the ALD. In 2010, Dr. Wyatt was a participant on an ADA panel that led to a publication with recommendations for adjunctive devices used in the detection of oral cancer. Tonight's webinar has been approved for 1 hour of prescribed credits through the AAFP. Application for continuing dental education credit has been filed with AGD, and determination of credit is pending. Questions and comments can be submitted to the presenter throughout the presentation. To submit a question to the presenter, please type it in the Q&A box that you see located at the bottom left-hand corner of your screen and click the Submit button. In addition, there will be an extended question and answer session at the end of the presentation. So without further ado, ladies and gentlemen, let's welcome Dr. Alfred Wyatt.
Thank you very much, Ms. Jackson, and welcome to all who are attending this webinar. I appreciate you coming in to observe and at least take an interest in diagnosis, prevention, and treatment of oral cancer. Oral cancer is something that we don't see very often. And you know, when you don't see something very often, you tend not to see it at all, unfortunately, even though it may be there in its very smallest stages or its very minute stages. But what I wanted to do this evening is present an approach of prevention, diagnosis, and treatment of oral cancer that you may not have thought about, and give you a few facts concerning oral cancers and maybe some things you might want to do in your own private practice. We as primary care physicians, and I will say primary care physicians because we are physicians of the mouth, have a fiduciary responsibility to diagnose those diseases that will occur. And oral cancer is one of them. The disclosure statements: I do not have any financial or other relationships with the manufacturer of any commercial services discussed in this particular educational activity. Many of you have heard or talked about having oral cancer screenings, doing oral cancer screenings, or performing an oral cancer screening, or devices or different products that may help in oral cancer screening. Well, personally, I would like to say that there is no such thing as an oral cancer screening, because you can't find out whether a lesion is oral cancer or not just by looking at it. There is no device that will pick up an oral cancer in the mouth. The only way that you can find out if something is oral cancer and officially make a diagnosis is by performing a surgical biopsy and having those slides read. Otherwise, you cannot tell someone that they have oral cancer. Second, when you tell someone that you are doing an oral cancer screening, if you find a lesion, the first thing that patient thinks is, oh my goodness, do I have oral cancer? Majority of time, you do not have oral cancer present in that situation. So it gives the patient much more apprehension when we use oral cancer screening. I personally like to use a full comprehensive soft tissue oral exam when we are looking at all patients because we're going to find lesions. And when we find those lesions, we have to find out what the origin of those lesions are and what may be causing those lesions. Eventually, those lesions may lead up, in some cases, to become oral cancer. But we don't want to bring apprehension to our patients and to the people that we diagnose, saying that, or allowing them to think that they have oral cancer when we find anything. Now, who are you? We're general practitioners. We're specialists. We're clinical staff members. All of us are looking into the mouth at some particular point in time. And the saying goes, 4 eyes are better than 2. 8 eyes are better than 4. The more eyes that you have making an evaluation of the mouth, the more things that will be seen at that time. Your present level of screening diagnosis: you're performing a thorough routine visual head and neck examination. This head and neck examination is not just intraorally but extraorally. We're looking at the patient's face. We're looking at the symmetry of a patient. We're looking at any lesions, discolorations, or anything that may be unusual about the patient when we begin these examinations, as well as looking thoroughly on the inside. Once we have completed the examination, we use enhanced visible light to see areas much better, to see the changes in coloration of the tissue, to see if there are any white areas that shouldn't be there or red areas that shouldn't be there. We also use brush biopsy techniques where we may scrape some of the tissue away to make a preliminary evaluation of the tissue to find out whether we should make a further evaluation of the tissue by doing a surgical biopsy by removing architecturally intact tissue. That means taking away tissue with the cells intact such that they can be properly read by an oral pathologist. And once the oral pathologist reads those slides, the oral pathologist can then render their opinion as to whether or not the lesion is benign, malignant, or what type of disease this particular lesion might hold for us. Tonight's goal: understanding our role as oral health care providers in the discovery and management of these oral mucosal conditions, especially the potentially malignant oral diseases and oral cancers. We will see that we have the major role in this. Now, this is a website called oralcancerfoundation.org. Get a lot of very valuable information from this particular website. This website was started by a gentleman by the name of Brian Hill. He's not a physician. He's not a dentist. By the way, Brian Hill's not even in the medical field. Brian Hill was diagnosed with stage 4 oral cancer. And upon his diagnosis, he realized that he had never received a full head and neck examination from his dentist at that time. So Brian Hill sued his dentist. Brian Hill sued his dentist and won. And when Brian Hill won that suit, the only thing Brian Hill asked for is that dentist consent and make sure that on every patient from this point forward that they did a full and defined oral examination on each person that they saw from then on. When I say defined, a patient needs to know from you as a dentist and a practitioner that when you enter, I'm going to do a full oral examination so that I can evaluate anything that might be abnormal, anything that might be unusual or suspicious that may exist in your mouth. Now notice I never said anything that might be cancerous. You might mention we can do anything from an ulcer or something that may even be possibly cancerous, just to give them a wide range of the possibilities that may be found during this oral examination. Subsequently, Mr. Hill formed this website, Oral Cancer Foundation, and this website basically gives information, several pieces of information that help people who have been diagnosed with oral cancer and give them a sounding board of people to talk to, of resources that they can go through to help them get through this particular condition as best as they possibly can. There is a problem. Oral cancer is the only form of cancer that the morbidity rate has not decreased in the last 50 years. And we have to ask ourselves, why is this happening? The 5-year survival rate of oral cancer is 52 to 54%, which is very low. Higher death rate than malignant melanoma, Hodgkin's disease, testicular cancer, brain, kidney, ovarian, and cervical cancer. 1 American dies every hour from oral cancer, and a late diagnosis is the problem that leads to this very high death rate. Also, oral cancer is the 6th leading cause of cancer in the United States of America. So, why then does oral cancer seem to be the stepchild of cancers? As you can see this narrative from the National Cancer Institute, they discuss several different cancers: bladder cancer, colon and rectal cancer. But you notice missing of all of these cancers is oral cancer. It's nowhere to be found. Here's another item on the website of the National Cancer Institute, and if you go to this website of the National Cancer Institute, you will see today that under the types of cancers, oral cancer has not been mentioned. We've got to make sure that oral cancer is at the forefront. This past year in 2011, 12,170 new cases of cervical cancer were diagnosed in the United States. Compare that to 40,000 new cases of oral cancer that were diagnosed. That's 3 times more cases of oral cancer than cervical cancer that were actually diagnosed. Moreover, there were 8,000 deaths from oral cancer last year in 2011 compared to only 4,000, well, not only 4,000, but 4,000 deaths per year from cervical cancer, meaning you had twice as many deaths from oral cancer as you do from cervical cancer in 2011. The scope of the problem: oral cancer is 90% curable if it's caught in its early stages. But the problem is 70% of the oral cancers that we see are diagnosed in the late stages, stages 3 and 4. And 60% increase oral cancer in adults under the age of 40 within the past 3 decades has caused a new spiral or a new concern that clinicians have to be aware of. 25% of those cases don't fit the profile of a high risk, of what we used to consider a high risk patient. So we had to ask ourselves, where are these cases coming from? Why are we now beginning to see oral cancer in patients under 40 when we used to see oral cancer predominantly in patients who were over 50? Previous risk factors for oral cancer that we used to consider were tobacco use and excessive alcohol use. Those were the primary causative factors of oral cancer that we would see in mostly Caucasian and African American men over the age of 50. Now we fast forward to nearly 5-fold increase of young oral cancer patients under the age of 40 who do not smoke, who are not partaking in excessive alcohol. And this underscores the fact that we need to do a thorough oral examination on every patient, at least over the age of 18, and in my opinion, we need to do a thorough oral examination on every patient over the age of 10, because we have been finding that there are oral cancers that have become predominant in teenagers. The reason is the human papillomavirus. HPV-16 is a human papillomavirus that is also found in cervical cancer as well. It's found in 60% of oral cancers and is now the most common cause of oral cancer that we know of. Now we have to ask ourselves and look to the fact that HPV-16 is found in cervical cancer, as well as HPV-16 being found in oral cancer. Ask ourselves a question: is this a communicable disease? Now, HPV is a communicable virus. It is a contagious virus. It is a sexually transmitted virus. By HPV being sexually transmitted, should we be concerning ourselves with people who are having oral sex and transmitting HPV from cervical to oral, or from oral to cervical? Is this a causative factor? Which is a question that we are now beginning to pose. We also have to think of it from the perspective that young ladies are now being vaccinated for Gardasil to prevent cervical cancer, and we want to get on our soapbox to say, well, why aren't young men being vaccinated as well against this HPV virus? Because if they're transmitting the virus via either traditional sexual contact or oral sexual contact, then maybe the men need to be vaccinated as well. And this is a point that's being discussed amongst several people in the medical community as to whether these vaccines should be administered to men as well. The paradox: it is not the tobacco-associated lesions that even have the highest risks of malignant transformation, but those which appear to be idiopathic. Now, back in 2003, they thought this disease process was idiopathic, but now they have learned that these disease processes are more related to the HPV-16 than anything else. So what should the real goal be? We should be able to decrease the morbidity rate of oral cancer by over 70% within the next 10 years. And the way that we will be able to decrease that morbidity rate is by one thing: by being able to diagnose these cancers at their earliest state. Because as I already stated, if we catch them early, 90% of these oral cancers are curable. So whose job is it? Whose job is it to find these oral cancers? Whose job is to make sure that these oral cancers are found early? The discovery and diagnosis of oral cancer is primarily responsible of not only the dentist, but all of the people who are in the mouth: the dentists, the hygienists, the dental assistants. All of the people who view on the inside of the mouth are responsible for taking a look. And as well, anyone who is evaluating the oral cavity is responsible for looking for these conditions. But the dentist is the primary healthcare provider for the mouth, and therefore the primary responsibility lies with the dentist. Dr. Alan Drennan, a professor at Buffalo, made the statement that all soft tissue lesions should be considered cancerous until proven otherwise. Now, does this mean that we need to biopsy every lesion that we see in the mouth? Absolutely not. But we should be suspicious of the origin of every lesion that we see in the mouth. We should know where each lesion originates from. We should know why it's there. We should evaluate why it's there, and then we should be able to correct the presence of that lesion. Many times when we evaluate lesions in the mouth, they may be of a systemic nature. They may be of a nature that is physically being caused, such as a tooth traumatizing an area in the mouth. It may be because of dental work that is present in the mouth. There are many reasons why lesions are there, but the important thing that we need to know is the reason why they are there. So how many potentially malignant lesions have you discovered? How many have you seen? A bigger question is, how many cancerous lesions have you seen? Or how many lesions have you seen that were cancerous that you did not diagnose? Studies have reported that dentists failed to recognize oral cancer in 69% of the cases presented to them. And dentists miss almost twice as many asymptomatic oral cancers as they have found. So diagnosing oral cancer, especially in the early stages, is not an easy task. It's all about what you see. Take a look at this particular picture and look at it. When you look at this picture, what are you actually seeing? Some of you may see one thing, some of you may see another. If you look this way, you may see a young lady with her head turned. If you look another way, you may see an old woman with a thin chin with her head down. The question is, what do you see and how do you see it in the mouth? Many lesions look identically. We will see a lesion that's raised in pink, and we may think it's a fibroma. It may not be a fibroma. As we can see in these pictures, the dog looks just alike, but he has several different moods that go along with him. The dental practitioner's training, education, ability to perform an oral cancer exam may be minimized. A study was done of senior dental students at 5 dental schools in Texas, California, and Kentucky, and it showed that up to 75% of the graduates indicated an uncertainty or the lack of ability to recognize malignant and pre-malignant lesions. Are we educated enough to find these lesions when we should? Are we educated enough to recognize them and see them and do the necessary things we should to make an early diagnosis? Recent graduates have higher level knowledge on risk factors in screening than experienced dentists. We find that most people who come out of school have much better skill level than dentists who are already out. So our dental profession needs to be much better trained experienced dentists need to be much better trained on what we need to do, how to diagnose lesions, how to look at, and protocols that are involved in making early diagnosis of oral cancer. Approximately 1,000 dentists and hygienists were screened at the ADA annual session for oral cancer, and roughly 10% of those hygienists and dentists had an oral lesion at that time. So oral lesions are out there. So in 1,000 people, you'll see 100 lesions. You'll see lesions every day in patients. A gentleman by the name of Scott Benjamin, who I give a lot of credit to, who has been in the forefront of making early cancer diagnosis by the general practitioner, actually did a study in his practice. And he did an adult non-high-risk population and looked at over 1,300 patients. And he found that 460 of those 1,300 patients had some type of soft tissue lesion in their mouth. Now, this oral cancer fact, only 14% of United States adults over 40 claim to have ever been screened for oral cancer or ever had an examination where someone was looking for lesions in their mouth. And also, only 7% of U.S. adults claimed to have been screened last year. So we have to at least inform our patients that we are doing these oral examinations, that we are looking for lesions, so that they understand and have an interest in the fact that we are looking for more than just teeth, and we're also evaluating for diseases of the mouth. The possible reason, most dentists say, damned if you do and damned if you don't. If they find it, then there's a problem and I don't know what to do with it, so I would probably rather not find it. So therefore, you normally don't see people doing these oral examinations or sending these oral examinations away, and the patients are coming away undiagnosed. The failure to evaluate oral lesions that may be precancerous, even when you do not expect them of being so, is inexcusable, and it does make you liable. And that's a very, very important point to find as a general practitioner. You must recognize these lesions when you see them and at least identify them, and if you don't believe that they're cancerous, at least identify the fact that you have a concern about a lesion, or you have seen the lesion and you have made some type of notation concerning the lesion. This is an oral cancer malpractice litigation statistic. If anybody can guess what the average award settlement against dentists was for failure to detect oral cancer was in past years. The average oral cancer settlement was $874,500. That's probably the highest awarding of a litigation of any particular malpractice of a dentist. What was the average age of these patients? About 45 years old, which is much less than what we used to consider the older or the predominant risk, the patients who were in the predominant risk factors. Now we're going to talk a little bit about the science of oral cancer, the progression of oral cancer, and go into the basic science of oral cancer. This is the epithelial tissue, and if you evaluate the epithelial tissue from a cellular level, you can see the superficial level, which is about 3 or 4 layers, and then you get to the intermediate level, and then to the parabasal level, which is right above the basement membrane, until you get to the stromal cells and the collagen fibers and the matrix and the bloodstream that are below them. Malignant transformation process: when a cell becomes more dysplastic, the nucleus of the cell becomes much larger. As you can see on the left side, in a normal cell, the nucleus of the cell is very, very small. But as the nucleus begins to change from an inflammatory cell to a dysplastic cell, all the way to a cancerous cell, as you can see in the cancerous cell, the nucleus is almost the size of the cell within itself. So what you're looking at is the nucleus to cytoplasmic ratio when the pathologist is evaluating malignancy and non-malignancy. Here is the malignant transformation that will occur. In mild dysplasia, we begin to see a change in the cells, but the cells have not crossed the basement membrane. In moderate dysplasia, you will see a further progression of changing of the cells. Severe dysplasia, which is also called carcinoma in situ, and by the way, the term precancerous has been eliminated, and now we're just looking at severe dysplasia and carcinoma in situ in these areas where you have a proliferation of cells that are changing above the basement membrane. You will have, but in severe dysplasia, you have several malignant cells. Once these malignant cells have crossed that basement membrane, and I will go back so that you can remember the basement membrane and where it is here. Once these cells have changed and crossed this particular point, then now these cells have gotten into the bloodstream of the patient. Once these cells get into the bloodstream, you now have an invasive squamous cell carcinoma, where the carcinoma is beginning to spread in this area and throughout the body. You have a malignant lesion at this particular stage. This is an evaluation of a patient who came in complaining of a denture sore. When it was evaluated, it was finally seen as a squamous cell carcinoma. These are some of the things that we see that we see too late and that we miss. This particular lesion should have been diagnosed long ago. Another problem that we have is many times our patients who have these type of lesions will not come in. We do not see these lesions in many of our patients until the very end stage of the disease process, until they get to stage 4 and it is too late. So previously our screening tools have been a 2x2 gauze, mouth mirror, an incandescent light, and human eye. And we have been missing a lot of lesions with these things. These particular tools are the same tools that we've been using for the last 100 years. Now there has been a change, a paradigm change. We have magnification that we're beginning to use. We have digital cameras that we can use and take pictures of the mouth and find lesions in areas that we can send to the pathologist. We have visible light enhancement that we can shine on the lesions, that we can see differences in the colors of the lesions much better. And now we have illumination enhancements with products such as Visalite and other forms of illumination. Or we have fluorescence and filtration devices such as Velscope, such as the Identify 3000, which is a handheld fluorescent device. Our method of diagnosis. The field of view techniques are sensitive. We can discern the abnormality patterns by recognition and comparing the images and comparison of imaging and features that are similar and dissimilar. We also have site-specific point techniques that are specific, identifying what is wrong via palpation, biopsy, and other techniques that we have available to us. Now, before I go on, I want to know if there are any questions of the people so far, any concerns about what we've already discussed.
Give them just a few minutes to type it in if they do.
Okay.
Dr. White, you brought up a point that I was wondering when you talked about the delay in treatment, is that many of our patients, when you work in a underserved area, just don't come to the dentist, for one, because they can't afford it, they don't have dental insurance, and it hurts. People just don't want to come to the dentist. And so I think about me as a primary care provider, that it needs to be better done in our offices to encourage people to come. Just
Correct.
Like we say, have you had your mammogram? Have you had your colonoscopy? Have you been to the dentist, other than just to...
Exactly. It is very important that our population come in and be evaluated fully from head to toe. And the dental exam is one of the most important pieces that we can do, because we can diagnose so many different types of diseases, not just oral cancer. I have diagnosed many patients of mine with hypertension and diabetes just lately because of their oral examination. They would have not gone in to see a physician other than had it not been for a toothache. So it is very, very important that we get our population in to evaluate diseases, evaluate their oral tissue, their oral health, because oral health is total body health. Okay, let's talk about the soft tissue exam. How should we approach a complete oral evaluation? The first thing we want to do is outside the patient's mouth. We want to evaluate that patient, the facial symmetry of that patient. Look at the patient's eyes, and you can do this without staring at the patient and not talking. You can do this with your introduction to the patient. As you introduce yourself to the patient or see the patient for the first time in the operatory, evaluate them as you're talking to them. Evaluate to see if there are any swollen areas. Are there any swollen areas in their cheeks, swollen areas in their faces, raised areas in their mandible or their maxilla, unusual areas in their eyes or their head. Evaluate anything that might be unusual in the symmetry of that person. This is a diagram, a coarse diagram of the lymphatic system, and it basically just shows you where in the head and neck many of the lymph nodes may be. You'll find that many of the lymph nodes run along the neck, along the sternocleidomastoid. They run sublingually near the thyroid. They run all the way submandibularly. They run posteriorly to the ears, and we should be able to know and reacquaint ourselves where these lymph nodes are and how these lymph nodes follow. Here's another diagram of the deep lymph nodes, and once again it mentions many of these lymph nodes that we've seen in the first diagram. You start by, after you have evaluated, you start by palpating for those lymph nodes. Are you feeling anything raised? Are you feeling anything fluctuant or fluid filled? Are you feeling anything hard in these areas? Slowly and gently palpate the areas along the sternocleidomastoid in the neck on both sides. Slowly palpate the areas of the jaw in and around the ear. On the inside of the ear, slowly begin to work toward intraorally. Evaluate the lips and take your fingers along the lips to find if you feel any suspicious lumps or bumps. Many times these lumps or bumps may be mucoceles or may be areas where someone may have bit their lip or trauma areas, but at least identify them and let the patient know, I feel something hard here, I feel something soft here, so that the patient knows that they're evaluating and you're finding things in their mouth as you go along. You look into the buccal vestibule and look all on the side of the cheeks, look all on the side in the retromolar pad areas. Evaluate the areas in and around the teeth. Evaluate the tongue. Now the tongue, as we most know, the tongue and the floor of the mouth are the primary origin sites that we may find oral cancer. The lateral border of the tongue is evaluated by grabbing the tongue with the 2x2 gauze, pulling it or extending it as far as we possibly can, turning it so that we can see the full side or the full dorsum side of the tongue. Do that to the left side, do that to the right side. Also have the patient lift their tongue so that you can see up under their tongue and see the floor of the mouth to see if there are any suspicious areas, red or white, that may exist. You also want to evaluate the palate. Look at the texture of the palate. Evaluate the texture of the gingiva. Look for any areas that may be reddened, swollen, or unusual and may not look normal. Look at the soft palate. Evaluate the soft palate for red and white lesions. If you see a red and white lesion, find out why is it there. Ask yourself, okay, I see something unusual. Why is it there? Is it a rough tooth? Has the tooth been chipped and is it scraping in the area? Or is there some other reason why this area exists in the mouth? Remember, African American pigment and Caucasian pigment may be the same. Many times you will have something in between. These areas are normal pigmented areas and are not melanotic and melanomas. So you have to know what the normal is and the abnormal is as you begin to make these evaluations. From doing your light evaluations, you begin to do a further light assisted diagnostic evaluation. I'm going to talk about chemiluminance. Chemiluminance, by definition, is the emission of light. Is the emission of light without the emission of heat as a result of a chemical reaction. This happens when you take two chemicals and shake them together and you eventually get light from a device. We might see that at the circus, at the Ringling Brothers or the Universal Circus, when they sell the little light devices. These light devices get their light from the reaction of two chemicals that have come together that do not create heat. And they last as long as that chemical reaction will last. The device that we use for chemiluminance is the Visalite. The Visalite is a device that utilizes white light in an enhanced manner by combining these two chemicals, as well as toluidine blue on certain areas to help you see or to help you read areas that might be suspicious. By using this light, it enhances the tissue such that it allows you to make a better decision as to whether that tissue is normal or abnormal. As you can see, the light passes over the tissue, and as the light passes over the tissue, it will enhance the illumination of tissue that may be abnormal, in contrast to the tissue that may be normal. Sometimes patients will use an acetic acid solution to take off the superficial layer of the epithelium so that these areas can be enhanced. The second type of light diagnostic is a fluorescent diagnostic. With fluorescence is a luminance that's most found as an optical phenomenon in cold bodies, which the molecular absorption of a photon triggers an emission of another photon with a longer wavelength. Let me simplify that. When you shine a light on the tissue, that tissue will absorb that light. And once that tissue absorbs that light will either reflect from that tissue, that light will either absorb that tissue, and when the light is absorbed by the tissue will fluoresce, or else it will emit a light at a higher wavelength back out to you. And as it fluoresces in a different color. And you can see it through lenses and see it in a different color through your naked eye. The concept of fluorescence is such that at a particular wavelength, light will be absorbed by normal tissue. If the tissue is abnormal, then the light will not fluoresce, and you can see changes in that tissue. This is an example of a lesion that has been used with fluorescence. You can see this lesion here where the blue arrow has been pointed. This lesion has a dark area right around here that is not fluorescing or is not green like the rest of this normal tissue. Also, you can see this lesion here. With the naked eye, it may be missed, but when you use fluorescent technique, you can see that there is a problem going on here. There is some abnormality going on in this particular lesion. Once you have established through different methods, light enhance, fluorescence, chemiluminance, and made a decision that the lesion has not had a specific origin, that the lesion in itself, and let me say this, most cancerous lesions are not bilateral. Most cancerous lesions are unilateral. So if you see an unusual thing in an anatomical position on the left side that's identical to something unusual on the right side, it probably is not a malignant lesion. It probably has some of the systemic origin. But once you have made a decision that that particular lesion is unusual or does not have a specific identifiable origin, it's time to do some specimen retrieval or to take a further test. There are many types of specimen retrievals you can make a decision on. First of all, there's exfoliative cytology, and that basically means taking an upper layer of the cells. A pap smear is a type of exfoliative cytology by using a tongue blade. A brush biopsy is an exfoliative cytology, and a liquid-based cytology is a form of exfoliative cytology. In the pap smear, what we do, we either take a tongue blade or a Q-tip. We take from the side of the cheek, and after we take from the side of the cheek, we take those cells and put them on a slide, and we read them from such a way. These slides, by the way, are from Dr. Michael Kahn, who was an oral pathologist out of Tufts University. In the brush biopsy, you do something similar to the pap smear type of biopsy, except you use a brush and you scrape the epithelium to try to get into deeper layers. Once this epithelium has been scraped, this particular brush is placed on a slide and sent to a special laboratory that has a computer that actually reads the slides and evaluates the slides from that perspective. In liquid-based cytology, you also use a brush to collect the cells, but the brush is placed in a solution. That solution is spun, and that after the solution is spun, the cells are separated out, and those cells are actually read by an oral pathologist at that particular point in time. A biopsy is performed in several different ways, but once these other techniques have shown that there's a possibility of some abnormalities or some strangeness that may be going on within this lesion, you may elect to do some type of biopsy. A biopsy is a medical test involving the removal of cells or tissue for examination. And the objective of this biopsy is to remove an adequate amount of tissue from the appropriate location to obtain a proper diagnosis. When we say adequate amount of tissue, we mean it has to be a part of the lesion such that a proper reading can be given. It has to be at least the origin of the lesion as well as some of the base of the lesion that has been obtained. Otherwise, you will not get an accurate reading. You may get tissue or cells in there that are normal, and you may have needed to get other cells that could have been abnormal in that situation. The types of biopsies that we do: punch biopsy, where you take a very sharp instrument and punch a small area of tissue out. You do a scalpel biopsy, where it could be incisional, meaning that you remove only part of the lesion, or excisional, meaning that you remove a full portion of the lesion. Or you can do a laser biopsy, excisionally or incisionally. And the advantage of the laser biopsy is that when you're doing a laser biopsy, you will not get the level of bleeding to occur as when you would do a scalpel or a punch biopsy. The only thing is that when you use a laser, sometimes you may cause collateral damage to the tissue that may be in and around the lesion. You do not want to have that heat collateral damage to the tissue, because then the pathologist will have a difficult time in reading. I am going to stop here at this particular presentation. I will continue with this presentation on next week, and I will talk further about the oral examination. We will discuss techniques as far as how to go through the oral examination, how to make a decision as far as whether you should biopsy, whether you should not biopsy, and all of the various protocols that you should go through in a biopsy. I believe that there should be more general practitioners performing soft tissue biopsies, because 60% of those people who have been diagnosed and 60% of those people who have been referred to specialists for further diagnosis do not go to the specialist after the general practitioner has seen them. So it is important that the general practitioner take time to begin to look toward trying to do some of these biopsies themselves and helping to make a diagnosis on their own. This is the conclusion of my presentation for this evening, and I wanted to know if anyone had any questions or any concerns that they may want to ask concerning all of the material that has been presented.
Dr. White, I wanted to see if we could bring back one of the polls where you asked about the biopsies to get an idea about how many people routinely do biopsies. And then I had a follow-up question.
Okay. When we look at the
question,
go ahead.
Go ahead. I'm sorry.
No, I was.
Say,
go right ahead.
If you have general practitioners who've not been doing them, then how do you now learn? You know, can you take a course? Should you just go shadow an oral surgeon? You know, what should...
There are several courses that are administered. I do courses through the Academy of Laser Dentistry and actually doing laser biopsies and actually going through the processes of showing how to do our biopsies. Tufts University has an oral cancer symposium every year where they talk about biopsies, and there are different continuing education courses that dentists can go to learn the protocols. And many of the oral pathology labs, especially as I mentioned, I use Tufts quite often. These oral pathology labs will assist you in helping you to make and discern whether or not you should or should not biopsy. And remember, we do have the use of digital cameras and digital information now, such that if you have a concern, you can take a picture of a lesion, give medical histories, and forward them on to pathologists, and the pathologist can facilitate what you're doing so that you can go ahead and remove that tissue and remove it properly. I have a question from what is the ADA code for screening? There is not an ADA code for oral cancer screening. There is an ADA code that unfortunately I can't call right off the top of my head, for using an adjunctive device, meaning one of those adjunctive light devices such as the Identify, the Visalite, the Velscope, or some other adjunctive device. And to be honest with you, if you use a light enhanced device with acetic acid rinse, that's an adjunctive device. I believe it's I'm sorry I don't have that code right off the top of my head, but there is a code available for the adjunctive device. I have another question from Dr. Moses, and that question is, when in your opinion is it appropriate to refer lesion evaluation to an oral surgeon? I say that it is appropriate to refer the lesion to an oral surgeon, number one, when you do not feel comfortable enough performing that biopsy or going through making that final decision. If you feel comfortable enough that you have gone through the various protocols and gone through the various steps in seeing that this particular lesion this particular lesion needs to be questioned, then at that particular point, if you have the surgical skills, you may go ahead and remove them. If you do not feel comfortable that you have those surgical skills, by all means go ahead and refer to the oral surgeon, who at that particular point will then perform the biopsy.
We have a few more moments, so if there are any other questions or comments, then please send them in. Of note, as Dr. Wyatt mentioned, he will be our guest next week on Tuesday, the 31st, for the Oral Health Coffee Shop. We didn't have it on the first Tuesday because of the holiday, so we are going to have an Oral Health Coffee Shop next Tuesday, and it'll be at 8:30 Eastern Standard Time. He'll be back to continue this discussion on oral cancer. Because it is a coffee shop, we still may use some slides, but it's going to be lots of question and answer, in a low-key, informal setting. So I invite you guys to please come out next week, and as well tell your colleagues who may not have been able to make the webinar tonight, and also think about some more questions that that came up tonight that you didn't get a chance to send to us, and then he could take care of them next week on Tuesday.
Yes. Okay, we have a question from Dr. Sidhu. I hope I pronounced the name properly. As an adjunctive tool, what's the best one available in your opinion? I think that all the adjunctive tools have their place and have their advantage. I don't like to recommend one product over the other. I have used all of the adjunctive tools that I have mentioned and several other adjunctive tools, including the Identify 3000. I have used the Velscope. I have used the Visalite. I think they all have their particular place in the sequence of diagnosis. But none of those adjunctive tools, none of them, I say, will give you a diagnosis of oral cancer. All that they do is just enhance. Now, some adjunctive tools are somewhat duplicates of each other, such as the Identify 3000 and the Velscope basically are doing the same thing. They are using fluorescence. The Visalite primarily is using chemiluminance or an enhanced light system when you're trying to make a diagnosis. So I don't want to say that one is better than the other. I just would like to say that they all have their place in doing different things. And a matter of fact, the ADA has, in the paper that I was part of a panel of that was published back in 2010, does not recommend any of these adjunctive tests for helping to make a diagnosis, because at this particular point there has been no evidence to substantiate that these adjunctive tests will serve as the final end all to make a full diagnosis. But anything, I believe, that you can use additionally to enhance your particular gathering of information is a major help to you in making your final decision. And if you know how to use these properly, I say go ahead and use them, but understand that they all are limited at this particular point in time. The research does not back them up as of yet.
Well, thank you, Dr. Wyatt. I think that's pretty much going to do it for our time. I would like to say thanks to the audience for your questions. And again, Dr. Wyatt, for a very informative presentation. It'll be our pleasure to welcome you back on next Tuesday for the coffee shop. I also want to say thank you to our e-learning and IT specialist, Mr. Quallen Hare. Again, this Primary Care for All webinar series is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and Clinical Directors Network. This partnership allows us here at Primary Care for All to serve as a resource for the National Health Service Corps members. Direct financial support for this webinar series was made possible from the U.S. Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Clinician Recruitment and Services. PrimaryCareForAll.org is funded under a cooperative agreement. This presentation was recorded, and it will be available on the website in our on-demand section in about a week. Please also remember to visit the website in the share section for an oral cancer resources. I listed them under the general primary care in the links section. Also, see the calendar for August events. The CE quiz tab should be popping up as we speak. Please complete it in its entirety in order to receive your 1 hour of CE and/or CDE credit. Thanks to everyone, and have a